Good morning. This is Dr. McDaniel at GYN Corner. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Thank you for joining me at GYN Corner today. I apologize in advance. I've had allergies today, so I'm coughing, sneezing a bit. We're coming from the horse farm. And I'm staying in the car because it's quite windy. It's going to be disruptive for the audio. But it is a fairly nice day. A little chilly because of the wind. But it's sunny, not raining, so can't complain. And what's today? Today is Saturday, March 7th. So let's see. I've been doing the pregnancy series every Saturday from the horse farm. And last week I spoke about cervical ripeness, which is the term we use in obstetrics, which refers to how pliable and how ready, how soft, dilated, pliable, ready the cervix is for labor. And the usage of the Bishop score, which is how we determine in a universal terminology for the cervical ripeness. So the Bishop score refers to how long the cervix is, or what we call effacement, how open the cervix is, which is dilatation, how soft the cervix is, whether it's firm or hard, the positioning of the cervix, if it's way towards the back of the lady, which we call posterior, or if it's way towards the front, which we call anterior, and how low the cervix is, which is what we call the station. And those degrees of change have numbers associated with them. So if the cervical ripeness is 6 or less, it's considered unfavorable, which means it's a fairly poor chance of whether the lady's going to go into labor within the next 24 to 48 hours, and whether or not inducing or forcing the labor will be successful. Dr. Bishop deemed a cervical ripeness or score of 9 or greater to be adequately ripe for induction of labor. And the Bishop score came out in 1955. So today I'm going to speak about induction of labor. And induction of labor is basically mechanical or medical, pharmacological usages to force or to induce labor for a patient. And it's usually for medical indications. The baby needs to be delivered within a reasonable time frame, so usually within 48 to 72 hours ideally, to avoid medical problems or mortality for the baby, or sometimes mortality for the mother. And the first one I'm going to speak on today is balloon, or what we call Foley catheter. Foley catheter is really a brand name for a balloon catheter that is used, technically it's used to place into the bladder to drain the bladder. So it's a catheter that we can inject fluid in. It has a valve, and it blows up a balloon to hold the catheter in the bladder and through the other valve to drain the bladder. We can use it in obstetrics because it's a rubber catheter that can blow up as a balloon, and that extension can stretch the cervix. Foley or balloon catheter dilatation for induction has been used since 1861 by Dr. Barnes, who was a proponent and who initiated its usage in order to mechanically stretch the cervix. Stretching of the cervix allows for natural release of hormones, which we call prostaglandins, which will cause uterine contractions. Prostaglandins can be released naturally by the cervix through stretching, and they're also released through stretching, dilatation, and movement of the intestines. So prostaglandins are hormones which cause uterine contractions. And the balloon catheter, the Foley catheter, has basically different dilatation maximal volumes that it can achieve. So traditionally we'll use a volume of 30 mils. Excuse me. And stretching the balloon to 30 milliliters will usually obtain a cervical dilatation of 3 centimeters. You can also dilate it to 80 mils if you have a balloon catheter that accommodates 80 milliliters, and that will stretch the cervix to 4.5 centimeters. You can either remove the catheter at a set time, 12 to 24 hours, if the lady is not in active labor, or you can just remove it when you see it falls out. And when it falls out, it should always be, the cervix will always be approximately 3 centimeters if you use the 30 mil balloon. The most common usage is a 30 mil balloon. And that's really because most hospitals only carry the 30 mil Foley catheter. So the studies have shown that usage of the 30 mil Foley catheter, balloon catheter induction, along with Pitocin, which I mentioned previously, oxytocin is synthetic formulation of the hormone that the body produces naturally for active labor, for contractions. So the usage of the balloon catheter and Pitocin for an unfavorable cervix, which is a Bishop score less than 6, has been shown to cause active labor or to induce to active labor and delivery. Approximately 83% of women who undergo the catheter, along with the Pitocin. So it's a highly successful rate of induction to labor. Now, an induction of labor is deemed successful if the lady goes into adequate active labor. It's not necessarily, the endpoint is of course delivery, but it's not considered a failed induction if she doesn't deliver, if she needs a cesarean section or what we call an operative vaginal delivery, which is forceps or vacuum extraction. Sorry, it's considered successful if you get this lady from not being in labor to being in active labor, which I think I stated previously. Yes, I did. Active labor is uterine contractions, which are ideally between 90 and 120 millimeters of mercury, or what we call Montevideo units, every 2 to 3 minutes. So she gets into active labor, which is always regular, strong uterine contractions, greater than 3 centimeters of cervical dilatation for greater than 2 hours. And she should dilate at least 1 centimeter per hour, but realistically it's usually much faster than that. So Foley or balloon catheter induction with Pitocin augmentation is a viable, valid, and useful form of labor induction for a woman who has to have her labor induced for fetal or neonatal reasons. I hope that's been helpful information on balloon catheter induction. Thank you for joining me here at GYN Corner. Have a great rest of your weekend. Bye.